Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Sarah Tinsley, Courtesy Assistant Professor in the Department of Malignant Hematology at the Moffitt Cancer Center in Tampa, Florida. She will be discussing the use of targeted therapies in patients with FLT3 or IDH1 or 2 mutated AML, with a focus on the nursing perspective. This episode is part of a larger educational program titled MedTalk 2021. Nurses discuss current and emerging management strategies in AML. For more information on Dr. Tinsley, along with a link to the complete program, including a downloadable PDF covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what Dr. Tinsley has to say.
Thank you. So now we're going to turn to targeted treatment options, and those would be FLT3 IDH1 or IDH2 inhibitors. This again is our AML treatment overview. You look at patient and disease characteristics, and again, not eligible for intensive therapies on your left, and eligible is on your right. And so you'll see as we move through these that your IDH1, 2, and FLT3 mutation are on both sides of this treatment algorithm. So targeted treatment options for patients with FLT3 mutations. FLT3 mutations are caused by internal tandem loop duplications. There are other FLT3 activating point mutations. We do have medications that are FDA approved that target that FLT3 receptor tyrosine kinase. We have midostaurin and gilteritinib, and there are mechanisms of drug resistance, and there are ongoing clinical trials to try to really address those mechanisms of resistance. And we want to make sure that we optimally manage those treatment-related adverse events with these FLT3 inhibitors. So FLT3 is a receptor tyrosine kinase. This cytokine receptor is normally expressed in those myeloid progenitor cells, and it's expressed on the blast in most cases of AML. And we know that FLT3 mutations promote growth and blocks differentiation. So if it's on the blast, it causes an increase in those blasts. And so you'll usually see a high white blood cell count. And activating mutations occur in about 30% of AML cases. And we look to see if it's an internal tandem duplication, which occurs in about 22%. And we also have a tyrosine kinase domain, or a TKD, in 4%. FLT3 mutations make everything worse. They have a high relapse rate. They do have that high white blood cell count, which makes for a challenging problem because those white blood cells infiltrate all of our tissue and can cause problems. They can cause CNS involvement. And it occurs across all different subtypes of AML, even in APL, which you know that is usually our curable subtype of AML, and occurs in about 30 to 40% of APL patients. That's your acute promyelocytic leukemia patients, also known as your M3s. So frontline FLT3 positive AML patients are treated with first generation inhibitor, the midostaurin. It is the only FLT3 inhibitor that's approved by the FDA for patients with newly diagnosed FLT3 positive AML. Efficacy is limited though because patients develop resistance. We now have 2 second generation FLT3 inhibitors. We have gilteritinib and quizartinib, which are both being actively studied in the relapsed refractory setting and are being studied for frontline AML. So gilteritinib, it was approved for relapsed refractory, and it is being compared with midostaurin for the frontline setting. There's a phase 3 quantum trial looking at quizartinib plus chemotherapy versus chemotherapy plus placebo as induction and consolidation therapy in patients with newly diagnosed AML. These agents have been around for a while and being studied, but the frontline only is our midostaurin. Midostaurin plus chemotherapy for AML with FLT3 mutation improved median overall survival, CR rates of 59% for the midostaurin compared to only 54% CR rates for the placebo. This was a phase 3 trial of midostaurin plus induction chemotherapy compared to placebo plus induction chemotherapy. And again, they had to have a FLT3 mutation and be newly diagnosed. You can see it was 717 patients, and they were aged 18 to 59. We know that the median age for AML diagnosis is 68. So this is younger than the median age AML patients. And then induction therapy for daunorubicin and cytarabine, followed by consolidation with high-dose cytarabine. We have midostaurin plus chemotherapy, prolonging that overall survival and event-free survival. This is commonly used. These are showing you the adverse event profile of midostaurin. There are GI side effects, which are higher in midostaurin plus chemotherapy compared to placebo. You have your blood and lymphatic adverse events. Now let's talk about gilteritinib. This was the phase 3 Admiral study, which showed that gilteritinib prolonged overall survival versus chemotherapy alone in these relapsed refractory AML patients. And you can see the 1-year survival for gilteritinib out of 247 patients was 36.6%, and salvage chemotherapy was 19.2%. And then at the 2-year, it was 20.6% compared to 14.2%. These are some of the mechanisms of resistance. We have primary and secondary resistance. The FLT3 ITD variant, a FLT3 ITD 627E. There are different sensitivities of the FLT3 ITD variants. There's also the bone marrow stroma that contributes to primary resistance. And there are alternate signaling pathways that get turned on by the leukemia cells. So they figure out how to outsmart the agents. And then for secondary resistance, we get clonal evolution during the FLT3 inhibitor treatment, and we get overexpression of the receptor tyrosine kinase AXL. So as you know, many of our AML patients have multiple mutations. And so some of those change places as far as which mutation is driving the disease. This is really focused on nursing management of adverse events and FLT3-mutated AML treatments. Again, we looked at nausea and vomiting. So you want your patient to take antiemetics prior to the dose, take with bland food. They should be spaced 12 hours apart, and you don't make up a dose if a dose is vomited or missed. There are pulmonary toxicities with midostaurin, so you want to really tell your patients and their care team about what that would look like. What are those symptoms? That would be shortness of breath, trouble breathing, chest discomfort, a new cough. And then you would want to work those up if it occurs, but really helping identify that this could be a problem and then educating the family and the patient about what to look for. AML with an IDH mutation, we have enicetinib that is used for mutant IDH2. We have ivositinib for mutant IDH1. And we know that these can cause a differentiation syndrome, which can be life-threatening. And we want to educate again about what that looks like and then manage that if it arises. IDH1 and IDH2 mutations are not that common. They present in 8 to 15% of patients with AML. And those are your patients who have normal cytogenetics. So 46XX in a female, 46XY in a male. So this can occur if you don't have any cytogenetic abnormalities. These are proteins that are essential for the Krebs cycles. They catalyze decarbylation of isocitrate to alpha ketoglutarate in the cytoplasm and mitochondria. And then there are recommendations for IDH1 and IDH2 mutant. So for your patients who are not candidates for intensive chemotherapy and physiologically they are 60 years of age and older, you would want to treat them with an IDH1 or an IDH2 treatment or a venetoclax-based treatment. Other ones that include your low-dose intensity therapies such as azacitidine or decitabine or your venetoclax-based therapies. If we have a patient that is clinically stable and doesn't have a really high white count, we typically wait until we get their myeloid mutation panel back and their cytogenetics so that we can treat them with the drugs that will lead to the best response and best toleration. Now, looking at the study for enasidenib and your relapsed refractory IDH2 AML, this was a phase 1/2 study, and it was for the phase 1 dose escalation, cumulative daily doses of 50 to 650 milligrams. This is a pill that they take for 28-day cycles. They were looking at overall response rate, overall survival, and event-free survival. Also, in phase 1 studies, we're looking at pharmacokinetics and pharmacodynamics. And we have 4-arm phase dose escalation, and we have a phase 2 study. So there's lots of studies in this area looking at enasidenib. You can see the responses here. The 100 milligrams daily, 38.8% overall responsive. For all doses, it was 39.6%. And then you can see different types of responses as you go down this table. For median time to first response, 1.2 months. When it goes up to 9.4 months. And for all doses, 1.9 months. I think the takeaway from this is really that if the patient's tolerating it and they're not progressing or having problems, you keep them on the therapy because the response can come later. Taking a look at this in the overall survival and best response and dose escalation, probability of overall response is 8.8, complete response, 19.7 months. Even if they're not getting that complete response, their survival is greater than if they have no response. So those look like stair steps. So again, continuing in as long as they're tolerating it. And we do have that differentiation syndrome, which we talked about. And you can see at the 100 milligram dose, 11 patients are 7%, and leukocytosis, where that white count jumps way up. Looking at ivosidenib and IDH1 mutated AML, it was multi-center, single-arm, open-label phase 1 trial, 3+3 dose escalation, and there was a dose expansion there on the right with ivosidenib 500 milligrams daily. And the endpoints were safety and tolerability, maximum tolerated dose. And looking at CR and CRH, they were also looking at co-mutations and the IDH1 variable allele frequency. Like at what point of the VAF is it effective? That's something that we're looking at complete response as the best probability of overall survival. Response similar to the prior graph, you still have improved overall survival if they have a response that's other than a CR or CRH. That's hematologic and no response with the inferior survival of the 3. The overall survival around 14-month mark there. So again, looking at different side effects, adverse events of special interest. This is at the 500 milligram dose. We have grade 3 or greater leukocytosis. You would give hydroxyurea and you could hold the drug. No fatalities in that group. A grade 3 or greater QT prolongation on the ECG. So you really want to look at the EKGs when you're giving these drugs, and there are parameters for holding if the QTC is 500 or greater. And with this, you can reduce the study drug. This is what occurred in the study in 2 patients or held in 13. You also want to look at their medication list to see if there's other drugs that can cause that QT prolongation. The other thing we do is look at their potassium, magnesium, and other problems that can lead to QT prolongation. And then for IDH differentiation syndrome, any grade occurred in 19. So you give corticosteroids, diuretics, and hydroxyurea if there's leukocytosis. There were 6 individuals that the study drug was held, no dose reductions, permanent discontinuation, or fatalities. And these resolved with intervention in 17 patients as of the data cutoff. So things to be aware of. They do have like little cards that the patients keep in their wallets in case they're not being seen at your institution and they go to an emergency room. That outlines the drug that they're taking that can cause differentiation syndrome and then how you handle that. So for the diagnostic criteria for differentiation syndrome, it's based on at least 2 of the following signs or symptoms: dyspnea, unexplained fever, weight gain, unexplained hypotension, acute kidney injury, pulmonary infiltrates, or pleuropericardial effusions. So pretty scary stuff. And the differentiation syndrome management, this is from the phase 1/2 AML study. Again, treat with dexamethasone, 10 milligrams twice daily. You rule out other causes. If you think they could have an infection, you use your anti-infective agents and hydroxyurea. If you have that co-occurring leukocytosis, you want to put them on an anti-hyperuricemic agent for co-occurring tumor lysis syndrome. If they are having respiratory problems that are progressing, such as hypoxia, or have renal failure, or rising white blood cell count, or signs of DIC, you would stop that inacetinib treatment. And once you have improvement, if you're having improvement in the signs or symptoms, you want to make sure you can continue dexamethasone until significant improvement or resolution. This is really important. There's a long half-life with inacetinib, and if you discontinue the dexamethasone too early, and the differentiation syndrome just comes back again. And I did have some patients that this happened too.
Thank you very much, Dr. Tinsley, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, MedTalk 2021, nurses discuss current and emerging management strategies in AML, and to download the associated PDF from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.